All right, guys, this is the second part of week 5's review. We're going to be going over just little topics here and there that have to do with the heart, the electrical conduction system, the pathway of blood. So we're going to kind of bring a lot of the cardiovascular system ideas together in this review video. So the first thing we're going to talk about are ECGs. I basically just pointed out the different spots on an ECG and what they refer to, so we'll go through that quickly. I'm going to talk about some of the extrinsic regulation of blood pressure, of the heart rhythm, of the heart beating, how we maintain homeostasis. I gave you a handout that I'll go through again. And then we're also going to talk briefly about intrinsic regulation. So preload and afterload, I'll give you a better definition of afterload. I know I didn't give you one in class. And then lastly, I'm going to finish up with the blood circulation path and how blood travels from different tube to the capillaries back through a different tube. So we'll talk about that as well. So let's start over here with the ECGs. ECG stands for electrocardiogram or electrocardiograph. Actually, I'm not sure which one it is. Look that up, ECG, electrocardiogram or graph. I would think it's a graph because it's showing a graph. But anyway, there's going to be about 5 distinct parts, if I counted correctly. There will be your P wave, your QRS complex, and then your T wave. There's something different happening in each one. At P wave, your atria are depolarizing. We're just going to say depolarizing. That means that they are electrically active. They're electrically charged. They're ready to contract. So they're going to contract basically right after this depolarization. Remember, this is the electrical signal of the heart, not necessarily the actual motion, but it's when there's a bunch of positive ions flowing in. So atria will contract in between here. Then the QRS, this is the QRS complex that we call it. This is when the ventricles, so the big guys, are depolarizing. And at the same time, the atria are repolarizing. So that means they're returning back to resting membrane potential. So as the atria return to rest, as they're relaxing, what are the ventricles doing? Activating. So they're depolarizing at the same time. But then the ventricles eventually have to repolarize as well, and that's what happens in the T wave. So ventricles are repolarizing. So they're returning to rest, repolarizing. Okay, so that's all I went through with the ECGs. There are different ways that you can diagnose different conditions based upon what the ECG shows. You can look that up on your own time. It's really interesting. Ventricular fibrillation is really obvious because there's just no rhythm whatsoever. So you can tell a lot of different things by the ECG. We also talked about arterial pressure. So we take blood pressure. You know that it's systolic over diastolic, and the average is about 120 millimeters mercury over 80 millimeters of mercury. You might have seen mmHg. That just means millimeters mercury. That's the average blood pressure. But blood pressure can be calculated very specifically, and it can also change depending on what your body needs to do. And it can also change if you have a disease state or something's gone wrong. So we need to be able to basically regulate our blood pressure through homeostatic feedback mechanisms. So we're going to talk a little bit about both of those. First off, let's talk about the actual calculation. Arterial pressure, or mean arterial pressure, I said average because it's a better word, MAP, equals the cardiac output, so how much your heart's putting out every minute, times your peripheral resistance, so how much resistance your arteries are giving you when blood is pumped out. So, cardiac output also has its own equation. If you think about it, how much blood is pumped out per minute? Well, that means we're going to be taking the stroke volume, so how much blood is being ejected per pump, specifically in the ventricles, because the ventricles are going to be pumping through the arteries. Ventricles pump, measure the amount of volume per pump, multiplied by your heart rate, which is in beats per minute, right? So therefore, your cardiac output is how much blood you're pumping out every minute, all right? So think about this. If we were to increase either our resistance or our cardiac output, blood pressure is going to go up, okay? If we decrease either side, blood pressure is going to drop. Okay, so this is a direct relationship. I'm not sure what that's called in a proportional relationship. in math. Oh well. When one goes up, the other goes up. When one goes down, the other goes down. That's how I'm going to describe it. So the way we can regulate it comes in a variety of different forms. So I'm going to show you the sheet that I gave you, which says baroreceptors in homeostasis. Okay, baro means pressure, right? So baroreceptors means pressure. So when we look at baroreceptors, in the top, I think this is the top left for you, I could be wrong, it shows up on my screen weird. When homeostasis is disturbed and blood pressure decreases, well, you need to now increase one of these two options, right? So this guy's going down, that means that this has dropped, so we need to ramp this guy up. We need to bump up either a cardiac output or the resistance. So what does it do? Your sympathetic nervous system will be stimulated, so if you can read that. Sympathetic nervous system will be stimulated, release some epinephrine and norepinephrine, which will vasoconstrict smooth muscles in your arteries, narrowing the hole, increasing peripheral resistance, and your heart will actually contract a little faster. If it starts contracting faster, increase of heart rate, guess what? Blood pressure goes back up. Okay, so we're increasing resistance, increasing heart rate, and also how strongly the heart is pumping, therefore it bumps back up your arterial pressure. The reverse is true. Say if your blood pressure is increasing, okay, so over here, in that case, you want to chill out. So you're going to have your parasympathetic nervous system, the rest and digest section of your autonomic nervous system, be stimulated. So therefore, it's going to slow down the heart, okay, slow down the heart, decrease the strength of the stroke, and also relax the smooth muscle of the arteries, therefore opening it up, decreasing its resistance, right? So the parasympathetic helps bring your blood pressure back down, specifically after like a bout of exercise. So you're exercising, your blood pressure is pretty high, you're done exercising now, you don't need as high a blood pressure, so then your parasympathetic will kick in and start chilling out your body. Whereas during the exercise, well, you needed more blood pressure to get blood all the way through your body as you're using it. So your sympathetic nervous system is actually stimulated when you are going out for exercise, which is really healthy for you because it trains your body to deal with stress in a proper, healthy manner. Now, I did talk a little bit about the way we know if it's sympathetic versus parasympathetic. So sympathetic nerve fibers, they originate in a very specific section of your spinal cord. It's in your thoracolumbar regions. So if I were to say a nerve is being stimulated from the thorax, you would know that it's a sympathetic nerve fiber. It's going to stimulate you to exercise, to be very vigilant and ready for action. Whereas the parasympathetic nerve fibers, they originate in the other two, which is your cranial or cervical, craniosacral regions. So basically your lower sacrum and then your cranial nerves. So if I say, hey, there's a root ganglion coming from your C1, so your cervical 1 nerve, well, you know it's a craniosacral nerve, therefore it's going to be parasympathetic. So it's going to chill out the body, lower the heart rate, calm it down. Okay? Notice though, when I was talking about these different nerve sections, it does something very specific. So when it's sympathetic, the heart contractions are going to be stronger, and at the same time, it's actually going to constrict, so basically tighten up the smooth muscle of the arteries too. Whereas if it's parasympathetic, it's going to basically relax the strength of the stroke, and it's going to vasodilate, okay, to decrease the peripheral resistance. Okay. Those were types of extrinsic regulation of blood pressure and heart rate. So that's how we coined them, because it's coming from somewhere outside of the heart, whether it's a nerve, whether it's a hormone too, like if you have adrenaline coursing through your body from your adrenal medulla, that can also stimulate some energy and some strong heart rates as well. There's also intrinsic regulation of the heart. This means that it's happening within the heart itself. And the two that I will talk about are the preload and the afterload. The preload is basically how much volume of blood is in the ventricle right before contraction. This is what I want you to remember. The more blood that fills the ventricles, the stronger the contraction of the ventricles. This is called Starling's law of the heart. Starling's law. That means that with more blood volume, the stronger, I'll say stronger, the contraction. Think about it as a slingshot, okay? The more you stretch a slingshot, so the more the heart fills, the stronger it'll send off, the stronger it'll pump, okay? Whereas if it's not filling up very much, it's not going to be very strong, okay? But you also might ask this question, well, Mr. Jackson, when your heart rate increases for exercise, it doesn't have as much time to fill up. So it won't be stretching as much, so you won't be pumping as much, right? Well, as you're exercising, your blood's moving faster and faster and faster, so your ventricles actually fill up very quickly during exercise, still get a pretty good load of blood, stretch out pretty good, so it can contract very strongly as well. So that was just a question that came up in class that I just remembered. All right, and then the opposite is true. So the less blood volume, the weaker the contraction. Awesome, let's move on, and we're almost done. Sorry, that was preload. Afterload is basically the strength necessary to get the blood out into the artery, okay? So it's how strong that, it's a completely different, what's the word, variable. So whereas this one is the volume, the afterload is the amount of pressure it needs to overcome to actually get the blood out. So I didn't really talk about that all that much, so don't worry about it for a test. Now, pathway of blood. This is vital. Get it? Because it's like a vital organ. Okay. Blood originates in the heart, for sake of argument. The heart is going to pump in the same vessel-to-vessel systematic way, whether it's either in the systemic circulation or the pulmonary. If I say it's in the systemic circulation, that means that it's going to the body from the left ventricle. If I say it's in the pulmonary circulation, it's going to be going to the lungs from the right ventricle. Either to or from, either way. So systemic, it could be an artery, and then eventually gets to a vein, comes back to the heart, and then it'll go to the pulmonary artery, and back to the vein, and then to the systemic artery, and back to the vein, and the cycle continues, okay? So let's just talk about each vessel itself. Arteries. These are large. They are elastic, really close to the heart, because they have to stretch under a high amount of pressure. Okay, so as the heart's beating, your aorta is about the size of a garden hose. So it needs to stretch a lot as that blood's being pumped through it. Okay, so it's very elastic. Whereas if you get down more near the arterioles, these are going to be a little more muscular to help kind of propel blood through it. Okay, and it's smooth muscle, by the way. You can't control that. Once it gets through the arteries to the arterioles, which literally means tiny artery, it's going to go to the capillaries, and this is where the action happens. This is where gas exchange occurs. So you're feeding your tissues with oxygen and nutrients if it's in the systemic circulation. Now, if it's in the pulmonary circulation, so let's say in systemic, you're feeding your cells. But if you are in the pulmonary circulation, you are going to be basically getting oxygen back into your cells at your lungs. This is in the alveoli, the little air sacs of your lungs. So oxygen is going to be going into the the capillaries in the alveoli, getting a lot of oxygen, expelling all the carbon dioxide, and then returning to the systemic circulation once it gets back to the heart to feed the tissues. Great. From the capillaries, we go back through the venules, which means small vein, to the veins, which are bigger. And the biggest ones being your superior and inferior vena cava. You may have heard that in lab. Vena cava means vein cave, big opening. And then it returns back to the heart. Two sections I want to kind of point out. In the arteries, the blood is going to be moving quickly, okay? So high velocity. And it's also going to be pushing on the walls of the arteries a lot, so it's high pressure as well. high velocity, high pressure. On the vein side, we're going to hop over here, there's going to be medium velocity, but there's going to be low pressure. So blood still has to come back relatively quickly, but it's going to be at a very low pressure. The reason you, for example, when you donate blood, they poke into a vein is because it's very low pressure, so blood doesn't escape your body as quickly. If they poked you in an artery, they should be fired first off, and you would lose a lot of blood, probably about a gallon in about a minute. Happens very quickly. Arteries are high pressure, high velocity. At the capillaries, though, you need adequate gas exchange to happen. So these guys are moving very slowly. So slow velocity. Literally one blood cell can fit through a capillary at a time. So they're moving very slowly. It's like a very small stream that just came off a river, and it goes through a tributary, and then it goes into a tiny little creek. The water's moving very slowly, very slowly. That's the capillaries. But there's also an okay amount of pressure. So I'm going to say low to medium pressure, because the nutrients in the blood have to get out of the capillaries into the interstitial fluid, into the cells. So there's got to be a decent amount of pressure to actually force all that out to get to the cells themselves. And then, as we mentioned in the last unit, albumin is going to be a big player in pulling a lot of that fluid back into the capillaries before it gets into the venous system. Okay? Let me just double check that I got everything that I needed to from that diagram, which I did. We're happy about it. So next Tuesday, when we start talking, we're going to go a little more into depth about extrinsic regulation with drug targets. You may have heard of things called ACE inhibitors, beta blockers, alpha blockers. These are different classes of drugs that act upon the heart. They might block sympathetic nerve signals, they might block parasympathetic, they might mess with the channels of the actual pacemaker cells, whether it's a voltage gated channel or calcium channel. So we're going to talk about how those drugs can influence the activity of the heart next week. So stay tuned. Again, like and subscribe if you enjoyed this. Let me know if you have any questions in the comments below. And thanks for watching. I really do appreciate it, guys.